Morning everyone. Today's topic will be on cutaneous manifestations of diabetes and thyroid disorders. The cutaneous manifestations of in diabetics are seen in 30 to 70% of the patients, may precede the development of before the development of clinical diabetes. Prevalence, cutaneous manifestations prevalence is similar to type 1 and type 2 diabetes, though cutaneous infections are more common in type 2, whereas autoimmune related cutaneous manifestations are more common in type 1 diabetes. Good metabolic control may prevent and may help to cure some of the manifestations. Coming to the classification, it is broadly classified under the below headings: vascular, metabolic, necrobiotic, bullous, infectious, neuropathic, treatment related, and miscellaneous. In further Coming to the vascular manifestations, the most common is diabetic dermopathy. This is also known as shin spots. These are multiple round oval pigmented macules over the shins, especially on the thighs, forearms, and associated with hyperpigmentation and atrophy. It is more common in men compared to females. They should have at least more than 4 lesions to say it is diabetic dermopathy. It's a marker of microvascular disease and it has high correlation with diabetic retinopathy. It may be secondary to trauma or previous pyodermas. It represents post-traumatic atrophy, post-inflammatory hyperpigmentation in poorly vascularized skin of the lower limbs. Endothelial proliferation, positive deposits in the basement membrane of the blood vessels are the histopathological findings. It does not require any treatment. This is a picture showing multiple hyperpigmented macules with atrophy on the shin of the tibia. Rubiosis faciae or diabeticorum. It presents as rosy redness of the face. It's usually evident on the newly diagnosed diabetics. It is seen in 60% of the hospitalized patients with diabetes, associated with vascular tone and increased viscosity due to functional microangiopathy. Often, it's a sign of poor glycemic control. It returns to normal with improved metabolic control of diabetes. This is the picture showing redness of the face, though it is uncommonly seen in Indian skin type due to the color of the skin. Erysipelas-like erythema, it's a well demarcated red areas in feet and legs. It's painless. It doesn't have any systemic signs of infection. It's usually seen in elderly diabetics where the duration of diabetes is more than 5 years. It can have underlying bone destructions. It is due to the compensatory peripheral increased peripheral microcirculation caused by decreased perfusion due to large vessel disease. Spontaneous resolution may occur over weeks, but it may recur. This is the diffuse erythema of the extremities and few areas showing bullous eruptions. Pigmented purpura, it is due to the extravasation of RBCs from the superficial plexus. It can present as red macules or orange tan patches, frequently associated with diabetic dermopathy. It's increased incidence in elderly diabetics with cardiac failure. It's again a marker of microvascular disease. This is the picture where you can see multiple pigmented purpuric lesions on the lower limbs. Perungual telangiectasia. It is seen in 49% of diabetics. It is nothing but the megacapillaries and irregularly elongated loops of capillaries. It's often associated with nail fold erythema accompanied by fingertip tenderness and ragged cuticles. It's also due to the functional microangiopathy. Tortuosity indicates structural changes in the vessels. This is the picture where you can see perungual telangiectasia. Now coming to the metabolic manifestations of diabetes. Most common is acanthosis nigricans. It is symmetrical in presentation, clinically presents as asymptomatic velvety verrucous hyperpigmented plaques associated with papillomatous skin tags seen in the axilla and nape of the neck, occasionally on the hands and feet and mucous membrane. Hyperinsulinemia stimulates insulin growth factor like receptors on the dermal fibroblasts. Treatment would be weight reduction, keratolytics, topical retinoic acid, and of course, maintenance of the diabetic status. This is the clinical picture where you can see pigmented, velvety appearance of the skin around the neck. Eruptive xanthomas, it occurs in less than 0.1 diabetic patients. It presents as crops of small yellowish papules with an erythematous halo. It may be pruritic and tender. Buttocks and extensor surfaces are the most common sites. It appears in association with elevated triglycerides. It resolves with treatment of glucose and lipid. This is the picture showing multiple yellowish papules on the extremities. Yellow skin and nails, it is seen in 40% of type 2 diabetes, more common in elderly. It is evident on the distal end of hallux. It's caused by hyperkeratonemia or protein glycosylation end products. Diabetic sclerodema, it's a non-enzymatic glycosylation of collagen, fingers and dorsum of the hands with limited joint mobility. Huntley's papule are seen in 80 to 50%, 8 to 50% in type 1 diabetics. It's usually seen on the chest, neck, shoulder. Presence has increased dermal thickness, difficult to tent the skin, pudy orange appearance of the skin. It may be subclinical at times, improves with tight glycemic control. Here you can see the picture showing thickened skin, and you cannot pinch the skin on the upper back. Coming to the next manifestation, that is necrobiotic manifestations of diabetes. Commonest is necrobiosis lipoidica. It is seen in 0.3 to 0.7 of diabetic patients. In 15% of the patients, it precedes the development of diabetes by more than 2 years. It's common in females, Caucasians, and especially in type 1 diabetes compared to type 2. Mean age of onset would be approximately 34 years. Clinically, it presents as well circumscribed papules, radial expansion, sharply demarcated, slightly depressed yellowish waxy plaques with erythematous raised borders, central atrophy with telangiectasia. The pathogenesis is due to the necrotizing vasculopathy causing collagen degeneration, leads on to granulomatous changes, further leading on to sclerotic changes of the skin. It is seen in the pretibial area, medial malleolus, 15% the patients have outside legs, that is lateral part. In 1/3 of the patient, it ulcerates. It persists despite good glycemic control. It has a chronic course. 20% may remit spontaneously in 6 to 12 months. Treatment would be intralesional steroids, aspirin, and pentoxifillin. This is the picture where you can see raised borders, yellowish tinged waxy plaque on the shin of the tibia. Disseminated granuloma annulare, there is no clearly established association between localized form and diabetes. Clinically, it presents as papules and annular lesions with red skin colors, erythematous border, and a flat center. Symmetrically distributed on the arms, neck, upper half of the trunk, less often on the legs. It runs a very protracted course. Sporadic therapeutic success reported with intralesional topical or systemic steroids, isotroin, chlorambucil, cryotherapy, chloroquine, nicotinamide, dapsone, and POA. This is the picture, the inner picture where you can see annular lesion, that is Papilla border with central clearing. Coming to the next is bullous manifestation. Bullous diabeticorum, it's common in type 1 diabetes mellitus, commonly in males, usually confined to feet. Very rarely you can see the bullous lesions on the hands. It is spontaneous, nothing related to trauma or any infection. Blister usually contains sterile clear fluid on a non-erythematous base. It heals in 2 to 3 weeks without any sequel. There are 3 types of diabetic bulla. Common type, wherein clear sterile blisters on the tip of the toes, fingers, heals without scarring. Hemorrhagic bulla, it heals with scarring. It cleaves at the dermoepidermal junction. Multiple tender non-scarring blisters in sun-exposed areas. It cleaves at the level of lamina lucida. This is one of the picture which showing diabetic tense bulla on the toes, and then spontaneous rupture, and there is an erosion at the medial end. Next would be the infectious manifestations. Bacterial infections are more common, either due to staphylococcus causing furuncle, carbuncle and ecthyma, or streptococcus causing cellulitis and erysipelas. Pseudomonas may present with cellulitis, osteomyelitis, meningitis, cranial nerve palsies, leading on to mortality in 50%. Treatment would be intravenous quinolones. Toenail infections, toe web infections are also seen due to Pseudomonas. These are the few pictures showing pyodermas, the bacterial infections on the skin. Erythrasma, it is chronic asymptomatic red scaly macerated plaque in the axilla and groin caused by Corynebacterium minucitum. Topical and systemic antibiotic can be prescribed. Other than that, there is non-clostridial gas gangrene develops in soft tissue near a gangrenous focus caused by E. coli, Klebsiella, Pseudomonas and bacteroids. Fungal infections, commonest is Candida causing mucosal candidiasis, vaginal or balanoprosthitis, intertriginous toe web space infection, paronychia and nail infections. Dermatophytosis incidence is increased in diabetics, commonly caused by Trichophyton rubrum, Trichophyton mentagrophytes, Epidermophyton flocosum. The first picture showing the erythematous changes in the submammary folds, nail infection and web space maceration, toe web space maceration due to the secondary fungal infection. Rhinocerebral mucormycosis caused precipitated by diabetic ketoacidosis, forms a black crust or pus in turbinate nasal septum, palate and orbit. Cerebral involvement is seen in 2/3 of the patients. Treatment is through debridement, IV amphotericin and treating the diabetic ketoacidosis. It is associated with high mortality rate. This is the picture showing mucormycosis. Coming to the neuropathic manifestations, here due to the diabetic neuropathy, there will be anhidrosis or compensatory hyperhidrosis in the trunk. Neuropathic ulcers will be circular, punched out with callosity over the metatarsal heads on the foot. Then the treatment related, most common is insulin reactions. The immediate reaction would be localized or generalized erythema and urticaria. Delayed would be itchy nodule 4 to 24 hours after injection. Lipoatrophy, circumscribe depressed areas starting after treatment. Lipolytic component of insulin preparation, immune complex mediated inflammation causes lipoatrophy. It's less common with purified recombinant human insulins. Lipohypertrophy is soft nodules resembling lipoma, local response to lipogenic action of insulin. It's prevented by changing the injection sites. Acquired perforating dermatosis, it's umbilicated hyperpigmented papules with central keratotic plug. Site would be extensor surface of the extremities. Pruritus is a major symptom. It's strongly associated with ESRD. Histology shows transepidermal elimination of degenerative elastic collagen fibers. Treatments would be topical tretinoin or phototherapy. This is multiple keratotic papules seen on the extremities. Vitiligo, localized or generalized forms of vitiligo they'll present with. 1 to 7% of the patients with type 1 diabetes will present with vitiligo. Maybe a part of polyglandular syndrome type 1. Treatment would be sun protection, topical systemic steroids, phototherapy. This is the picture showing multiple depigmented macules and patches over the body. Lichen planus, these present with polygonal violaceous flat-topped papules on the wrists, dorsum of the feet and lower legs. Oral genital lesions also you can find present with white lacy pattern. Topical steroids would be the treatment of choice. This is the picture showing multiple violaceous flat-topped papules with excoriation marks. So next would be thyroid diseases. The skin manifestations of thyroid dysfunction may be divided into 3 categories. Direct action of thyroid hormones on skin tissues, skin manifestations of direct hormone actions on non-skin tissues, autoimmune skin diseases associated with thyroid dysfunction due to autoimmune etiology. Direct action due to hypothyroidism will include epidermal changes, coarse skin, thick and scaling. Dermal changes would be non-pitting edema on the lower limbs, edema of the hands, face and eyelids, carotenemia and pallor. Hair and nail changes, dry, brittle, coarse hair, alopecia, loss of lateral third of eyebrows, coarse, dull, thin and brittle nails. Sweat glands involvement causes dry skin, decreased sweating. Thyrotoxicosis, epidermal changes will be smooth, thin skin. Hair will be fine hair associated with alopecia. Nail changes would include shiny, soft, friable nails, onycholysis and plumber nail. Skin manifestations of thyroid hormone actions on other tissues would be cold intolerance, pallor, purpura, drooping of upper eyelids, nerve entrapment syndromes are seen in hypothyroidism. Thyrotoxicosis, warm skin, heat intolerance, increased sweating, hyperpigmentation, erythema and telangiectasia. Skin diseases associated with autoimmune phenomena include dermopathy, that is pretibial myxedema, urticaria, pruritus, vitiligo, pernicious anemia, bullous disorders, eczema, and connective tissue disorders. Thyroid clubbing of fingers, toes in Graves' disease associated with soft tissue swelling of the hands and feet with periosteal newborn formation. It occurs in less than 1% of thyrotoxic patients. It usually associated with exophthalmos, pretibial myxedema. It's called as Diamond's triad. Proximal phalanges, first and second metacarpals are commonly affected. Most patients have minimal or no symptoms, but in those with symptoms, stiffness is more frequent. This is the picture showing pretibial myxedema and thyroid acropathy. Pretibial myxedema, localized edematous thickened pretibial plaque, occurs in 10% of the patients with hyperthyroidism. It's usually a late feature occurring after ophthalmopathy and diagnosis of hyperthyroidism. Also occurs on the dorsum of the hallux, may affect other sides including the lower abdomen, arms, shoulder, neck and pinna. The lesion first appear on the anterolateral aspect of the lower limbs, later extend to the back of the legs and feet. The nodules are pink or skin colored, sometimes it may be yellow or browny, with waxy consistency, prominent hair follicles giving a pudy orange appearance. They may occur in old and recent scars. Localized pruritus or hypertrichosis over the lesion may be a feature. Localized hyperhidrosis has also been reported. Three clinical types are recognized. Sharply circumscribed in both nodular and tuberous lesions appear on the shins and toes. Diffuse, producing solid non-pitting edema of the shins and feet. Elephantiastic, in which there is both edema and nodule formation. Here the picture is showing elephantiastic type of pretibial myxedema. Thank you.